Um, how do you measure actually your disease? One, we can measure by time. You can call acute if it happens within 6 weeks of event, like this cataract surgery. Doesn't matter whether it's a SICS or fecal emulsification. We have delayed after 6 weeks. Now, the time of 6 weeks is actually, believe me, arbitrary, because many years ago, BGO published it by some of those stalwarts in endophthalmitis management. So somehow world agreed to become 6 weeks, but then you can make it 4 weeks, you can make it 8 weeks if you want. But certainly, we called mild, moderate, and severe by the vision. Vision is more than 2200, that means 660 in our Snellen chart. We call it mild. Moderate if it is up to hand motions, then severe if it is light perceptions or less. Certainly by microorganisms, since we talk mostly about the bacteria and fungi, we talk about a gram-positive or gram-negative bacterial infection or a fungal infection, whether it is a filamentous or yeast. And finally, we talk exogenous, endogenous by mode of entry. All traumatic endophthalmitis has to be exogenous because it happens after trauma. Intraocular surgery, not extraocular surgery, also can cause exogenous endophthalmitis. Endogenous is all from the body spread, whether it is a cancer, immunocompromised patients, body septic, or carditis. These are some of the examples. In the left, to your left panel, we see so we call it a mild infection. Why? Because there is a huge amount of vitreous antichamber flaring cells. We can see a small amount of it working here. There is actually a membrane. We can see a little gap here. Membrane is forming or breaking out. In the right is a very severe, no light perception, extended to the sclera infection, gone out. Most probably you can't do nothing to this eye, as called the very severe endophthalmitis. As you told that mild are always antechamber cells and flare, hypopyon will be there, could be there, but less than a millimeter. Then the moderate vision is 2200, and then we'll have a vitreous exudates start appearing in moderate endophthalmitis. Severe, the dense vitritis usually happens in a fungal infection, and there is no fundus view. Antechamber might be full of hypopyon, and you may not see a red glow also. And very severe is scleral extension, as we showed you. Functionally and structurally, you can also divide endophthalmitis based on the present visual acuity. That is what EVS endophthalmitis vitrectomy study used. That they say that if it is a treatable endophthalmitis by vitrectomy when vision is hand motions or less, and injectable by different antibiotics, they selected ceftazidime and vancomycin for when vision is hand motions or more. Structurally, based on the involvement of ocular tissues, whether it is a cornea, iris, antechamber, vitreous, and retina, like this. We designed something else called the inflammation score that combines both structure and functions, and then used it in our own randomized clinical trials. We'll talk in the next presentation, called the endophthalmitis management study. To measure the inflammation, we designed many years ago, in 1999, published in British Journal of Ophthalmology, about how to objectively score the inflammation associated with endophthalmitis. We divide into 4 ocular structures: cornea, antechamber, iris, and vitreous. Each one has got 2 components. Example, cornea has got corneal edema and abscess. Antechamber has got flare cells or hypopyon fibrin. Iris has got new vessels in the iris or exudates over the iris, and vitreous has got a flare and opacity. Each one divided into 0 to 4 scale, where 0 means all good and 4 means all bad. It can have so happen that supposing you take cornea and there is so much of corneal abscess or corneal edema that you can't go beyond, you can't examine iris, antechamber, iris, and vitreous, then you have to give a higher score. That score is below shown in below highlighted, that you add some numbers. So those numbers are at 20, at 15, depending on or 10 or 5. This was a modified version of a paper published by Travis Meredith many years ago that was done on stap epi rabbit model of endophthalmitis. This is modified that for human use, and this is being used very successfully. And by that, you can actually divide the endophthalmitis by inflammation score into mild, moderate, and severe. We decided that mild endophthalmitis is one where your inflammation score is less than 10, 1 to 9. Moderate is 11 to 19, and severe is more than 20. By that definition, we have shown some pictorial one, the most left has got a nearly clear, no corneal edema, nearly clear iris, little hypopian, and some membrane over the iris, and the inflammation score is 6. We call it a mild. There is a surgical implication of that, of why we are talking mild, moderate, severe, or inflammation score between below 9 up to below 19 or above 20. Similarly, the middle one, we have an inflammation score of 12. We call the moderate, and last one is a severe inflammation, called enthymaitis of a more than 20 inflammation score. Before we started our endothelitis management study, we also did revalidation of what we have published before, and before we start the new randomized trial, that we saw that by validation, the slit lamp photos examined by 4 different people, unconnected to the real examination of the patients, were all kind of congruous. There is really not many outliers. We also found that those who had a higher inflammation score are most invariably a gram-negative bacilli. In this particular case, it was Pseudomonas aeruginosa. We also, and we end the study, we also found out how the inflammation score and visual acuity measure. We found that as the inflammation score increases, logMAR vision also increases. That means vision actually decreases. When the inflammation score is less and your vision is more, logMAR score is less. So with that, we stop with this presentation,